of the year, depending on how things go. It's been an interesting year, to say the least.
Yes, indeed, sir.
All right, it is 5 o'clock, and as I just mentioned, for those who may have signed on just now, we've got a lot on the agenda to get through for hopefully our last meeting of the year. David's going to join us in just a few minutes. He's tied up with another meeting, so I'm going to turn it right over to Melanie to give us our opening announcements, and then we'll go from there.
Okay, great. So thank you, guys. So welcome, everyone, and can you guys hear me? Okay, so good evening. We just want to remind everyone the meeting's being recorded. In the event the meeting is breached, please hang up immediately, and then I will send you an email through the MDPCP mailbox with a new meeting link that will allow you to log back in, and the recording will be available to the public. I see Dr. Sharp has joined us. Please contact Anena or Melanie or send a chat message if you're having technical issues. You can mute and unmute yourself using the small button at the bottom of your screen that looks like a microphone. Please remain on mute when you're not speaking to reduce the background noise. Staff may mute you if there's a lot of background noise, but you're always able to unmute yourself. You can use the chat function. It does send notes to all attendees. This technology does not allow you to send notes to specific attendees. Please announce yourself when speaking, especially if you're on the phone. Everyone's free to speak during the meeting. Since there are a lot of people, we try to sequence when possible. So please signal to the team that you'd like to speak. One method is to use the raise hand button that's on the bottom of your screen, kind of near where the video button is. It's over to the right side on the bottom. The other method is, and I don't have the envelope on me today, is the tried and true hold something up and David will call on you method, if you'd like to do that as well. And I'm probably the only one who still uses a ruler. Okay, so with that in mind, I will turn it back over to David. I haven't announced who's on the call. Okay, I've only done beginning more remarks so far. So I did not announce people yet.
So Melanie, for the record, can you sort of state who's on the call?
Sure. So far from the council, we have Debbie Cook-Craig, we have Jean Ransom, we have Dr. Haft, we have Kevin Hayes, Michael Barr, Dr. Reedman, Scott Rose, and Dr. Berenson. Did I miss anyone who's on the council who's on the call?
Hi, it's Stacia Cohen.
Hi, Stacia.
Good afternoon, Stacia. And good afternoon, everyone. Let's turn this back over to Dr. Barr and to see if there's any remarks. Can you scroll down on the agenda a little bit, Melanie, just to see?
Sorry. Yep.
And okay, we also have Laura Goodman from Medicaid that's joined. With that, Dr. Reedman, I was a few moments late. I didn't know if you had a chance to make some opening remarks or how you'd like to proceed at this point.
Thanks for joining us, David. I hope your other meeting went well. No, we briefly, I said that I wasn't going to do a whole lot of opening remarks today because we've got a lot on the agenda. It's our hopefully last meeting of the year. Just wanted to welcome everybody, and I'll start off and I'll end off by thanking everyone for the work that you put in the last difficult year. I think we'll have a good conversation tonight, but I'm going to cut it short and turn it back to you and Howard and our presentation so we can get things hopefully completed tonight.
Wonderful. Ben, any thoughts to start us off? Okay, so Melanie, just scroll down a little bit more, and then we can turn this over to Dr. Hack. There we go. Okay, Dr. Hack.
Yep. Thank you, David, and thank you, Michael. And I just want to restate great thanks that we all have for all the advisory council members' contributions over the many months that we've labored Tuesday night after Tuesday night in very serious and detailed deliberations over matters that are of extraordinary importance to the future of healthcare delivery across the state. None of these are easy questions to answer. None of them are answers that are already well prescribed and understood. A lot of them have to do with experience and judgment, and were it not for the great experience and the breadth of experience and that sits around the table, or now sits virtually around the table over these last months, it would have been impossible to reach the point that we've reached already. So tonight on the agenda, I think we'll restate those policy discussions and decisions that we've reached over the last several months that help form what would be the basis of the next iteration of Maryland Primary Care Program, Track 3, beginning in 2023 and then transitioning to the full complement and the only complement by 2026, and we would hope that becoming the permanent way we carry on primary care, at least for the foreseeable future thereafter. This is really monumental work, and to having gotten to the point we've gotten to in a short 6 months is remarkable in itself. So it's even more remarkable having been done in the context of this incredible, unprecedented, and devastating year that we've been through in the last year with COVID-19 and all of the issues associated with it, how it's impacted every aspect of the healthcare delivery system, particularly primary care, particularly the hospital system, particularly payments, and everyone. And the fact that we are culminating now with our deliberations at a time when we're beginning to see the dawning of the end of this period in COVID-19 with the advent today of vaccines coming to Maryland and the progression of those vaccines over the next several months until we can assure that we've vaccinated enough people to get herd immunity and see our way out of this pandemic. And the roles that hospitals have played, and the roles that primary care has played, and the role primary care will continue to play in that vaccination and testing effort is still going to be considerable. So the fact that we're doing all this at the same time we're doing those other things makes it even more remarkable. So my, unbelievable and undying thanks to all of you. Tonight we're going to, in addition to reviewing those policy statements and seeing if there's any additional comments or things that we need to add to that, we'll also add on to the agenda presentation by our actuarial contractors optimist group, and that will be Chris Welsh and Tim Doyle, who we brought on specifically to answer this, or begin to answer this question about what specific measures does primary care play a role in, that they have a preeminent and significant role that is not something that we can say is a measure that, yes, we're holding you accountable, but it's not something that you can impact or modify. So they've done some detailed actuarial analysis looking at that specific issue, so that it can give us some further guidance as we build the performance-based adjustments and build it based on weighted measures that primary care has impact on. I point out that that's different from looking at simple avoidable hospital utilization, avoidable emergency department utilization. That's not the work that they did. Clearly, those things will be part of what we look at going forward, particularly on the PQI aspects of that, and that's Those are measures that we have tools already, and we anticipate we'll use them. This is separately looking at those clinical quality measures that we would be wanting to select to include now and into the future. Last, I want to just bring you up to date before we go into our policy discussion where we are currently with our discussions with our colleagues at CMMI. We continue to be discussing and meeting about the issue about whether we would use average HCC scores as is designed in primary care first, or use the money follows the person or beneficiary measured HCC scores. And we've seen now iterated back and forth with them on different versions of that and modeling. Most recently, CMMI has suggested that if we sub categorize within the primary care first and do quintiles and then attribute different payments to those quintiles, that will get closer to what they're looking for and what we're looking for. And I think in the end, where we'll probably wind up is what we all want, is to make sure that we have a fair and balanced payment program for all of the practices, a payment program that as they transition from track 2 to track 3, neither significantly advantages nor significantly disadvantages any of the practices, that their general payments as they make that transition, as they cross that divide, is not significantly different. It's not 20% up or 20% down, but if there is a difference, it would be a negligible difference, so they could continue to carry on orderly operations with at least, but probably it will continue to argue a little more than what is currently offered in track 2. The little bit more and what that amount is going to be a separate discussion that will carry on, and I'm sure the first quarter of next year as we do continue these discussions with CMMI. But right now, I think we'll just want to make sure that that whatever model for HCC distribution we use, that it neither significantly advantages or disadvantages any of our practices, and allows them to live in the same revenue stream more or less that they've had before. So that's part of our continuing discussion. We'll be meeting again with them tomorrow. So even as we sunset some of the work for the advisory council for this year, we'll continue the work that we're doing with CMMI well into the holiday season and on into next year. So I'll pause there, see if there's any questions about that, and then we can start talking about the policy discussions.
And there's a hand raised, but it's by an unknown, so I'm not sure who that is.
I think it's Stacia. It's Stacia.
Thanks. I was just wondering, Howard, if you could comment, because I haven't heard much discussion about it, what the priority of this group would put on multi-payer alignment, because I do think we continue to dance around that topic. And if we want the commercials and Medicaid to line up as well, I think that some of the topics that we've talked about but haven't advanced are going to be really important. And so I'm not sure where everybody landed on that when I was out.
Yes, Stacia, I think that's a good question, and honestly, I don't think we looked at these issues that we talked about here in terms of multi-payer alignment, because our charge was to align with primary care first. To the extent that primary care first aligns with multi-payer alignment, I think it's not clear to me that was part of the charge here, because as you know, in primary care first, it's still a separate enrollment after the practices are enrolled to align other payers. But I would say that in terms of the state's perspective, we want nothing more than to continue to align with the other payers, clearly with Care First, which we've already aligned with, but to deepen and broaden that alignment along payments, along the lines of quality measures, in every way, in educational programs, in every way that we can. And clearly, there's a strong desire to align with Medicaid in the MCO program. So I don't think there's anything here that is designed to prohibit that alignment. But I think it would be fair to say it wasn't looked at through the lens of multi-payer alignment per se, because our charge was clearly to say, make it look like primary care first to the extent possible.
Okay, thank you.
Great question. So why don't we, Melanie, proceed by bringing up the policy document that Dr. Haft had sent around, and I think that takes us to our first point of the discussion. I would note for the council that we had Dr. Okiki join, and we have Tracy Lavelle from the Maryland Hospital Association filling in for Bob. Welcome. And I will turn it back to Dr. Haft. It's Dr. Berkowitz. I'm not sure if we got you earlier on the list of attendees or not, but welcome. And Melanie, you'll try to bring up. Okay.
Yeah, thank you, David, and thank you, David, for wearing the Johnny Cash outfit tonight.
I want to hear him sing.
No, you don't.
No, you don't. Does that need to be bigger?
I'm sure.
It would be good for me to be bigger, so thank you.
Okay.
Thank you so much. Yeah, so we'll run through this and pause at the end of each section to see if there's any additional comments or discussion. The overview is I think, as we've said, that our policy goal here was, as requested by our colleagues at CMMI, to align to the extent possible state model with primary care first, which is going to be the only primary care model after sunsetting CPC Plus, and that this would happen beginning as early as 2023. So we said that we would, in the very broad areas, we would make that alignment. We would shift from fee for service, which is the majority of the payments in the current primary care program, to population-based and risk-stratified payments, as we see in primary care first, with a fixed flat fee to supplement those for face-to-face visits. And the fixed flat fee would be an amount that would be neither a broad incentive nor a disincentive for those face-to-face visits, and that those face-to-face and that flat fee would allow for simplification of coding, and that would be billed at the same way that whatever the individual encounter would be. So if it was a level 5 encounter, it would be billed as a level 5 encounter. Co-payments would be collected according to a level 5 encounter, but the payment would be a flat fee.
So, pardon me, Dr. Haft, didn't mean to interrupt. Melanie, if you're having system problems, would it be easier if an Amy or
she's bringing it up. I don't have enough bandwidth to scroll down on the document.
Okay, so
sorry.
If we could size it a little bit larger, and then and Amy, if you could scroll down just a little bit to give Dr. Haft a chance to catch up. Thank you all. Sorry for the interruption. Dr. Haft, please proceed.
Yeah, and then we would be combining those payments, the population-based risk stratified payments in the program, together with the flat fees, and they would be considered a total primary care payment. And distinct from the current primary MDPCP program, there would be a performance-based adjustment that would be made on that entire amount, that both the flat fee and the capitated population-based payment, and that there would still be asymmetric risk applied to those performance adjustments, similar to what is in primary care first. We differed in details under each of those broad categories, but the broad structure is preserved, and the departures were from those categories in the ways that MDPCP and primary care first are different. And that primary care first is a model that tests things that are not part of a state overall program, that they are primary care first testing asymmetric payments and population-based payments, whether they reduce acute hospital utilization. And that is not the test for Maryland. We have a separate test, which is whether broad-based statewide healthcare transformation, together with population-based payments, will reduce, improve quality, and reduce total cost of care compared to a group of comparative states. So it's a different model, different things. So part of our overall goal is to make sure that if our model is going to impact broadly the total cost of care for the state and broadly implement healthcare transformation across the state, we need to assure that that we have broad implementation and not a narrow implementation as we see in primary care first. It doesn't cover entire states. We also need to assure that it aligns with the goals of the total cost of care contract, and specifically the state integrated health improvement strategy as part of that contract. So we needed to make sure that those alignments were there in terms of our performance adjustments, et cetera. And so that we needed to have some distinction. We, I think, established, and you can scroll down a little bit, that we would have touch on several items that were broad-based issues that needed distinction from what was in primary care first, and that was a track 3 payment goal. In primary care first, there is no specific payment goal that's specified, but we do have payment goals for being able to support our practices to do the transformative work that they do and support their patients. That we would have a discussion, which we've highlighted already, about performance-based, population-based payment structure, whether it was practice level or beneficiary level. We'll touch on that a little bit more. Balancing the flat fee and the population-based payments. That we know that both of those exist in primary care first, and we adhere to the concept of neither incentivizing nor disincentivizing a face-to-face visit based on the flat fee structure. But we did want to make certain that the majority of payments and the incentive was in the area of population-based payments, and not significantly incentivizing continued fee for service. We had a brisk discussion about asymmetric risk. We'll talk about that a little bit more later, but the highlight there is that we said that by policy we wanted to asymmetric risk, but acknowledge also that that practices, particularly small and medium-sized practices, may not be tolerant of large downside risk, at least not early on in the program, and that allowing them to weigh in over time on the asymmetric risk was a preferred way to approach the asymmetry in risk, both on the upside and the downside. We talked about performance-based adjustments and quality framework, and again said that performance-based adjustment and quality framework that is in primary care first is particularly for testing how these payments adjustments would affect acute hospital utilization, and that's not our weighted focus, and we look more toward weighted measures that would not have that would have weighted effects on payments rather than kind of cliff effects on payments that appear in the primary care first now, so that it would allow more gradations in terms of both the up and the downside. In terms of the asymmetric risks, the practices wouldn't stand to lose large amounts or gain large amounts if they had intermediate levels of performance. So that was our goal in that, and we put forward a framework for doing that. We discussed track 3 being a mandatory versus an optional status, and we'll talk about that. And I think our agreement was that we would phase out both track 1 and track 2 over time, and that track 3, if given all of the aforementioned policy pieces, could easily become the only way that practices are performing in the state. And then we talked about care transformation organizations' role in track 3. So that was the broad overview. I'll pause there. We'll go through each of those serially.
Dr. Haft, we have a question from Dr. Okiki.
Okay, good.
Yeah, Dr. Haft, I was wondering, just to confirm, that with this proposed payment structure, that unlike what we have now, it puts the care management fees, quote unquote, at risk as well, correct?
Yes, they're not care management fees, they'd be population-based payments, but that's exactly right. There's a larger, again, the design for primary care first is you put a larger amount of your total, or the whole amount of total primary care payment at risk, but there's also an asymmetric reward associated with that, and that's the design fidelity. Of course, it also our balance to that is that rather than putting it at risk at very large amounts, very often at 10% negative, either 0 or minus 10%, as we see in the quality adjustment framework in primary care first, we make that a broader and less severe risk framework, and make it based on individual quality measure standing alone, rather than all or not, either having to achieve all of the quality measures. If you fail one in primary care first, you fail all in the model that we currently use, and the one that we're presenting to CMMI. It continues to adhere to each measure stands on its own. So you can do well on one measure and you'll get credit for that, but not do so well on the other, and you don't get credit for that, or get relatively less credit for that, so that it allows practices to have a blended score rather than an all or none score.
So, my apologies, Dr. Haft. Go ahead.
Go right ahead.
Oh, so when we get to the policy elements here, is it your preference that the members take a few moments, read the policy goal here, and then sort of indicate whether it reads appropriately based upon the discussions the advisory council has had, or is it your preference to take a different approach here?
Sorry, Howard. I just wanted to, in the interest of time, what I'd like to say that you went through a lot up there, but we're going to go through each one of these individual items. So I would say that if someone has a question that's urgent, we can ask it now. Otherwise, I'd like to save the question for the end of each section, and I think that'd be more efficient. So again, if someone has a question now, that's fine, but otherwise, I'd like to go ahead and do it during each section. Okay.
So Michael, would you like then to leave the council members to have an opportunity to read through, see if they have any questions, and then move on? Is that what I hear?
Yeah, I think that'd be the most efficient, Howard, unless you feel otherwise. But
nope, that's fine. I'll add here at this point that for what we submit to CMMI, in addition to having these policy statements, has a fair amount of supportive detail in the modeling and discussion points that came from the council. So this is just if you will, just the policy statements themselves, without essentially the cliff notes, without the full detail.
Okay, so if everyone could just take a couple moments to read the policy payment goal here, and let's see if then there's any concerns or questions. And just as a reminder, as Dr. Haft and Dr. Reedman noted, this is a policy statement, and it's not to reflect the elements of building out the components of this section. And I think Stacia Cohen has her hand up. Is that correct?
Yes, that's correct.
Go ahead, please.
One of my questions about the track 3 payment goal, you mentioned wanting to make investment above current track 2. At what level, and what is has any actuarial estimates of the entire impact of that been done? I just would say, given the amount of discussion and concern that's been raised on the cost of the track 1 and track 2 without accountability, I'm concerned about us advancing a track 3 payment that's even higher without a more stringent accountability matrix. And so what can you share about that?
Yes, certainly. So the accountability, again, in this model, the total primary care payment is at risk. So this model moves accountability to the point where it is fully accountable. And in terms of actuarial studies, we've relied largely on what's been in the literature now. We haven't done a specific actuarial study on, and I'm not sure what that would be, but in terms of modeling around the per beneficiary per month amounts that are necessary to provide advanced primary care in the way that it's conceived in this program. We've also looked at the goals nationally from PCC, from other states. We've looked at some modeling that MHCC has done in terms of if there was if primary care payments were 10% of the total spend, what that would look like. And then again, where we are now currently in primary care in Maryland is about 3.5% of the total spend in Medicare, and what that would look like at different levels. And again, based on not so much actuarial, but on modeling based on what current costs for staffing, overhead, and other kinds of features would be. So we use those. I think this is still going to be a discussion point with our colleagues at CMMI, and but the council felt that the current level at a per beneficiary per member per month all in is somewhat less than what would be required for the full staffing complement and resources necessary to carry on this kind of
Perhaps I didn't ask that question as succinctly as I think the questions that will be raised. I'm actually less concerned about CMMI as I am about what this adds to the total cost of care target and the all payer rate setting. I think we're going to have a lot of questions from HSCRC about this, because this is going to, by definition, you're asking to increase the Part B costs
yes.
per beneficiary,
yes.
without without a lot of clarity about accountability for those increased costs. And I understand from our discussion last week that we're proposing allowing people to choose between 1% and 10% risk, but that these costs are not insignificant. So I'm just trying to think through all of the other people who are going to be weighing in on this outside of this group, outside of CMMI. And as you know, there's been no small amount of discussion about the additional financial burden this is placing on the waiver test. And so I'm just wondering what the conversation about that has been.
Hey, Stacey, I'd like to chime in on that one. I think that the discussion we had was that the program was intended to be also an investment in primary care. I think the issue with accountability, and it's come up in numerous times in some of our other meetings, is that there are other places to cut costs. There seems to be a push from the payers and the previous programs to make the primary care physicians accountable, but no one else. For the programs, a number of the programs we have, there's no specialty accountability. There's starting to be some, but the issue is that the accountability should be across the board, not just on primary care, and that this program should be, one, an investment in primary care. There should be resources to cover the extra additional costs of doing that care. And then there should be an incentive or a bonus if you achieve the measures that we need to have. So I think when you talk about accountability, it's bothersome when as a primary care physician when I hear that the 5% that we spend on primary care is a burden to the system, but that the specialist care have not been impacted by these programs at all. So I think that the bigger picture from the HSCRC, not so much this committee, should be that if we're going to put accountability, that accountability needs to be across the board and not just on the primary care physician. So I think this program, we're hoping to be intended to invest in primary care, cover the additional risk, and incentivize the physicians to do this, impact the things that they can impact, and be accountable for the things that they can be accountable for.
Yeah, I'm just saying, I think there are more people with a dog in this fight, and I think that we have not heard from MHA. I think MHA is on the phone. I'd be interested in their perspective about this, because I know that this has been a source of angst, at least for the last year. And so I just want to make sure if we're advancing something, that we aren't advancing something that's dead in the water before we've even moved forward, because we haven't considered what are the opposing views to this going to be.
So Stacia, just, so both HSCRC and MHA have participated on a weekly basis for the last 5 months, 6 months.
Yep.
So we're, I don't think this is not the time to, I don't think to seek some other opinion from them. I appreciate what you're saying, but I think we have discussed this thoroughly for quite some time.
Okay, I just wanted to make sure that this didn't get shot down as soon as it started getting circulated more broadly.
So thank you, Stacia. Dr. Haft, Dr. Reamer, we have questions. We're taking them in order of those who've raised hands. It's Will, Jean, Debbie, and Tracy, and I think Dr. Berenson. I wasn't sure if I noticed. No. So why don't we start with Will?
Yeah, thanks. Thanks, David. So Howard, you mentioned we've been part of this conversation for 5 or 6 months, and I think that's true. I think we've been pretty consistent in saying, I don't think that the goal of fixing the fee schedule for primary care was an initial selling point or policy objective of the primary care program. That was to align primary care doctors with the hospital's incentive to reduce unnecessary utilization, to make the total cost of care model more successful, to produce care transformation, et cetera, et cetera. I think we've had significant mission creep, or maybe a mission switch. I'm not seeing alignment with the total cost of care model, care transformation, et cetera, as part of the policy objective. I do think there are very fair problems with the physician fee schedule and compensation for primary care doctors in particular. I am concerned about, using a program that started off as being trying to align the total cost of care program across the delivery system to accomplish that when that's not what we're going to be evaluated on by CMS, or, sort of to Stacia's point, the internal policy conversation about the total cost of care model.
Okay, Dr. Haft, is this something you want to respond to, or just note it as a comment?
Nope, note as a comment.
Okay, thank you, Will. Jean.
Well, actually, I don't agree with what Will just said at all. I think this whole program is about aligning with waiver, and I don't think there's been any mission creep at all. And I think what we're doing is we're trying to meet CMMI in the middle with what they've expressed concern about, and I think this moves us in the right direction. And I'd like to know if his statements that he just made were the statements of the HSCRC Commission or his own, just for clarity. My second comment is I agree with everything that Dr. Ryman said, but I also wanted to point out that at the HSCRC meeting this Wednesday, the accountability issue was resolved the commission voted to make CTOs that are hospital-based CTOs accountable. It's a major change to the program that I think that we've agreed to take. So that solves the problem, frankly. Since it's such a big major change and a new level of accountability, I think we need to go at least a year to see what that accountability means and how it will affect the program before we try to make new measures of accountability on top of the accountability that we've already done. So I think the primary care program is being very flexible and trying to work with HSCRC on their concerns. And you'll notice that, MedChi did not object at all to what the HSCRC wanted to do. Obviously, I would much rather have no accountability for my physicians who work in hospitals, but they felt it was important, and that's fair. And I think that, we'll move forward with that and see how that change occurs. But I do think we need to note that action. I think this is a reasonable step, and we should send it to CMMI and see what they say, and they can get back with accountable.
So again, Dr. Haft, it sounds like this is a very good point, and so noted. There are Will Daniels has raised his hand and maybe to answer the question of Jean. With your indulgence to the group who had already hands up, I would suggest Will to respond.
Thanks, David. So just in response to Jean's question, I can't speak for all HSCRC commissioners. You'd have to ask them. I can speak for HSCRC policy, which was approved at the last commission meeting. I think the perspective expressed by the commission there was that there was insufficient total cost of care accountability, that the option that we were employing was a second or maybe third or fourth best possible solution, having real accountability endogenous in the program. I think that we do not feel like that was resolved with what HSCRC did, and the commission, I think, very clearly said, if we get to a point, and hopefully we do get to a point where there's real accountability built in MDPCP, we wouldn't have to do sort of the HSCRC bootstrap approach, but sort of absent sort of accountability in the program. I think the commission felt like it was necessary to do what we can with the levers that we do have.
Debbie, and then Tracy.
Yeah, good discussion. I remember when a couple of meetings back when we talked about, the risk factor. We were very concerned at that time, Stasia, about increasing participation, or at least holding participation constant, because we recognize we have to engage in order to bend the curve. So I think it's a balancing act. Having said that, I also recall stating we really do need to believe in this program. But it is, in my opinion, totally unrealistic to think that we're going to achieve savings. I think many of my colleagues on this council have said it time and time again, to think that we're going to see savings in the first year of a program when we didn't know who we were managing and we didn't get the data until the end of the year and we weren't staffed up. So to me, all this conversation about risk reward and bending the curve, I keep coming back to the horizon in which we're expected to get results. And in that context, I think we do have to consider, what the state's arrangement is and what the expectations are by CMS in terms of our metrics overall. The other comment I'll make, and Howard, I know we're going to go through these different components, but there were more things, I think, in general that we disagreed with primary care first than we agreed with. So when I read the introduction of this paper, I recognized the need for diplomacy and that it's a negotiation. But I also don't want anybody to misunderstand the many concerns that this council expressed over week after week about trying to force, primary care first on our program in Maryland. Because I think we see many more disconnects than we do agreements with the program. So just the elephant in the room.
So thank you. Tracy, and then I have sort of a directional point to make. Tracy.
Yeah, thank you. So I wanted to switch gears a little bit and talk about the piece on CTOs. I can say briefly that MHA, we agree with the comments Debbie made and also the comments that Jean made in regards to accountability and cost, and that we see the importance of investing in primary care. But on the CTOs, I was wondering if we might consider adding just another sentence or two that says not just why CTOs are important, but why they should be part of the Medicare program. And I think what we've talked about in the past is that having a set fee structure and a particular way to outreach that's coming from CMS is a way to help and support recruitment of practices, especially the newer practices. So that we might want to include some of that justification to CMS of why the CTOs should be within this model, not just that they're a good thing to do, but so the standard agreement and the standard cost.
David, you're muted. David, you're muted. Okay.
Sorry, guys. All this red color gets me confused from time to time. I wanted to remind everybody, just as sort of a directional beacon here, CMMI, just as a quick reminder, has said to us that they want a framework of just policy and presented to them before the end of the year. And what Dr. Haft is presenting to us tonight is a reflection of the discussions that have largely occurred, as Dr. Riedman noted, for many months. I think the points that the council is making are spot on, but I think, as Dr. Haft and Dr. Riedman has said, we'll get opportunities to incorporate additional feedback once CMMI responds and says they'll say something like, okay, go ahead and develop the program elements for these three particular areas. And as Dr. Riedman noted, the council will get lots of opportunity to start having these granular discussions, which is some of what I think we're beginning to do today, and sort of gives us an insight to what we have to work with in 2021. So I would just note that a little bit in the interest of time, but also to sort of keep us focused a little bit, your comments won't get lost, and they're not going to get forgotten. We are going to come back to this, but we first have to get a framework, CMMI, for them to even give us the green light to even come back to these conversations. So unless Dr. Riedman, Dr. Haft, if you think I'm mistaken, please speak up. But it seems like we just have to look at the goals of each one of these, the policy statements, say, does it kind of reflect the overarching message that we were trying to send? And then we'll come back to all these concerns as we go into 2021. Is that fair to say, Dr. Haft?
Yeah, I think that's very fair. I think this is not the end of the discussion. It's really the beginning of what will be many more months of discussion. Hopefully not every Tuesday night, but many more months of discussion. And to the payment goal, I want to just remind everybody that the underpinning for the payment goal is to provide sufficient resources for primary care to do the work that needs to be done to make a healthier state. I think that is a mom and apple pie goal that is not able to be attacked in any way. There's work to be done in longitudinal care management that's critical, ongoing acute chronic care and prevention, behavioral health integration, social determinants of health. All those things require investments. They can't be done just because we want them to be done. And the matter of fact is that, of the $1,200 per beneficiary per month or so that Medicare pays for care for beneficiaries, even with these investments, this would be a tiny percentage of that. We're talking about less than 10% out of that entire amount, much less than 10% out of that entire amount. So we're not talking about taking over the world in this. We're just talking about providing sufficient funding. And I think that's where the bar is set. It's sufficient for.
So there's two comments, and then I would propose that we move forward. I think it's Stacia and Will. Stacia, I think you had your hand up first.
Thanks. I just wanted to clarify. I was just trying to understand what policy we're trying to advance. I think that we are all in radical agreement about the importance of primary care. I just know I've heard enough commissioner conversation, and having been at the commission, hearing the questions being asked about the investment here, that we're going to be asked those questions, and I want to help ensure we can advance something that can be successful, because people have put a lot of energy into this.
No, understood. And, I think the matter of fact is the reason we're doing this to begin with overall is that with the entire transformation, which is both a good and a bad thing, is that on the hospital side, we were the highest per beneficiary per month hospital in the country, payments in the country. So we're not, this is a shifting. We had the lowest, among the lowest for primary care, among the highest for hospitals. Within the framework, it allows for shifting of those payments while still meeting targets. I think that's exactly what's happening here.
So, Will, did you take your hand down, or you still have a quick comment to make?
Sorry, I had my hand. I forgot to take it down.
No worries. So let's travel along a little bit. Dr. Happ, do you want to summarize the PVP?
Yeah, I think we did before. And again, we looked at primary care firsts. Practice level beneficiary, modeled that out, and found that the majority of our practices, almost all of our practices, were either in group 1 or group 2, which were very low in terms of the payments for those, and significantly disadvantages the practice. So we went back to, and we've continued to iterate and negotiate with CMMI and saying that that's unacceptable. And our goal is to make sure that we don't disadvantage practices financially as they move from one spot to another. CMMI has held that if we do beneficiary level payments, that it does not align with primary care first, because those aren't population-based payments. It strains my imagination why they're not, but that's not the important point. The important point is that we will look to wind up is a model that neither significantly advantages nor disadvantages practices as they move from track 2 to track 3. So that'll be our discussion as we continue with them, even as soon as tomorrow.
Okay. Are there comments from the group on the way the policy is worded, which is states the recommendation for the policy is use beneficiary level HCC scores? Okay, hearing none, we can travel on. Dr. Happ.
So the next item was balancing flat fee and population-based payments. As you remember, the total population payment is the combination of the risk stratified population-based payments, wherever that lands, either on the average or the beneficiary level, together with a fixed flat fee. And the part of the intention of the overall program, and something that I believe that primary care providers currently and into the future will recognize, is that there's some real frailty in being tied to fee-for-service payments. We saw that in great measure during COVID. We continue to see it, and we'll see it again now with the surge again of community transmission, which restrains somewhat considerably restrained the visits early on in the year, and probably restrain them somewhat now also. And that linkage to fee-for-service has been noted to be not beneficial to primary care, probably not beneficial in many ways to other aspects of the healthcare payment system, but particularly for primary care. This moving to population-based payments is a very strong way of moving away from fee-for-service into into value-based and population-based payments. What we want to make sure here is that we value those flat fee payments so that they don't overwhelm the population-based payments, that the majority of payments are on the population-based side, so the practices are uncoupled from having to be on that treadmill of having to see more and more patients in order to meet their income levels to provide necessary revenue to do the work. That the majority of that comes from being paid based on their population that they serve, not on the number of faces that they see every day. So that was the balance here, is to move the balance further toward population-based payments and have a relatively neutral flat fee. And we've done modeling for many weeks to see where that levels are, and we'll continue to have that discussion with our colleagues in CMMI. But it will look like something, and not to give it a specific number, but something, before cost sharing in the range of $70 to $80, given the progression of given what was given to us in primary care first at their level, marching it forward to 2021 using the GIPSY adjustments, and then cost sharing adjustments on top of that would be related to whatever the specific level of service was under the 2021 fee schedule. So it winds up being very close to numbers that we modeled in the beginning, while still emphasizing population-based payments.
So, Dr. Haft, is it fair to say that the detail will be there'll be opportunities to talk further about it when the program elements are refined a bit in 2021?
Yes, and the policy statement here is that we're moving further toward, and to the extent we can, into population-based payments, de-emphasizing fee-for-service.
And is it also correct to say that the dollar amounts is as part of the policy statement are not included in what we're sending to CMMI?
That's correct.
Thank you. I think Stacia Cohen had a comment.
No, I forgot to take my hand down. Sorry.
No worries. Any comments to the information, Dr. Berenson?
Yeah, well, it hasn't been mentioned up till now, but the question is whether in primary care first and in this program, whether telehealth will be considered a fixed fee visit or not. I don't think we have to solve that this year, but I think that's an issue that there's a lot of interest in paid parity. Do we consider paid parity for this fixed visit, or is that part of the population-based payment? So I'm just having it as a placeholder for going forward.
And Dr. Berenson, we can go back, but in the RFA, it does talk about the population-based payment. One of the reasons why they quote unquote say it's higher is because the funds can be used for additional care management, can be used to cover telehealth. So there is some discussion, and we can, as we get into the end of the year, beginning of next year for the council, pull that out specifically.
Well, I think that's fine, but the RFA, I assume, was written when telehealth was a small little marginal activity, as opposed to what it is and may remain.
Yes.
So the stakes have been raised a lot, and I'm sure that CMMI will be revisiting that on a national basis.
Yeah, fair enough. Good point. Thank you. Other comments here? Okay, Dr. Haft.
So great comment. Next was asymmetric risk, and I think Stacia commented on this earlier also. And so I think the ranges. I think our policy approach here is that rather than having a fixed minus 10% and up to 50% upside, that we would allow a range of initial and subsequent risk levels. They would still keep the asymmetry in the same format. However, they would practices will be able to start low. And I don't know whether it says negative 1% here, but I don't know that that's the number that we'll wind up but at some negative number that's not minus 10%, and then move up over time. And start at an upside of, could be 5% or some other higher number than that, but move progressively up. We haven't specified the time, but there's a 5-year run on the program, so it would be within a 5-year period that they would then achieve over 5 successive steps a top level of risk. This would allow practices to initially to be adjusting revenue-wise and performance-wise to those risks. They would be required to, at least as we've discussed it, to move up over time. They would not be allowed to move down over time. I think that's also the case for primary care first. So I think that was a policy statement there.
And I think what Dr. Haft has noted again is that the ranges will be determined in consultation with the members here in that next year. I think, is that fair, Dr. Haft? Is that what you're, or do the ranges?
I don't think this is, so any of these numbers, whether it's my negative 1% or 10%, I don't think, or these are carved in stone at this time, and they will be up to some discussion.
Okay. Any comments from the council? Okay. Dr. Berenson.
Yeah, I don't know whether you want to get into it, but there have been a number of conversations about, I think the consensus is that there should not be insurance risk. Performance risk is reasonable. Do we want to make a statement somewhere, either here or somewhere else, affirming that?
So, Dr. Haft, is it possible to add where we see downside risk, we just sort of note that it's performance risk and parens?
Yeah, I think that's a great idea. I think we had a good discussion about that last week, and this clearly is not insurance risk, it's performance risk.
Thank you, Dr. Berenson. Okay. Seeing no other comments, Jean's commenting on that. Yes, thank you, Jean. Dr. Haft, I think we can proceed to the performance-based adjustment.
Okay. So in performance-based adjustment, this here we have set as a policy that we wanted to have a simplified version of a performance-based adjustment, and something that would allow for a broader range of performance adjustments, with measures being individually weighted rather than weighted as a block of all of the performance measures, pass or fail, and put together a straw man of that over the last 2 weeks, and presented that to the council. That whether that straw man is how we'll do that or not, but we also presented some design features and principles around ease of administration, ease of understanding, the ability for primary care to impact the measures in which their performance would be adjusted, and an annualized adjustment rather than a quarterly adjustment. I think those were the kind of the key features in what we put forward.
Okay, Debbie.
I was just wondering if you had any insight into how receptive they would be to that annual, because when we got into that cash flow and, the conversations about how important that is to the practices, I think that that's a really important point and variation that we're pointing out we need. Any predictions?
It's really hard to predict. It's particularly hard to predict now because we're in the, at the end of one administration and the beginning of another. So we don't really have visibility at all on what the incoming administration leadership will look like. I think there'll be some level of leadership at CMMI and CMS that will remain in place. But upper leadership and the direction of upper leadership that is, the administrator, the director, is, I think, yet to be named, and so we'll have to see. Clearly, if we can take some any indication from the named but not yet confirmed HHS secretary, there seems to be a real direction there in terms of improving quality, lowering costs, focusing on less consolidation at hospital level, those kinds of things. So we'll see. All that's conjecture now.
Thank you, Debbie. Dr. Barr.
Hi, good evening. One quick comment. I support the annual performance adjustments. Do we want to make the point, though, that the quality reporting would be more timely, more regular? It's not made elsewhere. So it's annual performance adjustments, but regular reporting on quality, whatever the period is, less than a year.
Yes.
That's a good point.
So Dr. Barr, this is probably a little bit off track here, but we're having some discussions both with our colleagues at HSCRC and in Medicaid about developing systems over the next year or several years where we can have continuous quality reporting both at the practice level and at the reporting level, and I think that's our lofty goal. It's a little off the four corners of what we're discussing here, but I think it's a very important point.
Yeah, the point is, of course, practices shouldn't be surprised by a performance adjustment in either direction. They should know where they stand during the year, so they can make adjustments.
I totally agree.
Good point. Okay. Hearing no other comments, Dr. Haft, I think we can move on to the CT role in track 3.
Great. So this is an issue that we have received opinions from CMMI on, and our policy goal here is to retain CTOs as formal partners at MDPCP, have them continue to receive direct payment such as is directed by practices as part of their payment structure. Of course, that would have to change. It would no longer be a portion of a care management fee. It would have to be structured in a different way, but we would like to retain the formality with the state continuing to manage the arrangements between practices and CTOs, to continue the state to manage the overall state CTO organizational structure, meetings, and communications, and keep that system intact. So that was our policy statement. CMMI has no objection to having care transformation organizations. Their objection was to having them have a relationship with CMS and CMMI through the participation agreements.
Okay. Thank you, Dr. Haft. Any comments here? Okay, seeing none.
Dr. Barr and Dr. Okiki have their hand up.
Oh, my apologies. Dr. Barr.
It's not up anymore. That was from before, sorry.
Oh, okay. Dr. Okiki.
So the way the last sentence reads is that if CMMI has indicated that they don't have the interest to provide oversight or administer the CTO arrangement, that the state is willing to take that on. Is that accurate?
So no, it's not so much. So we've already through the program management office, we do all of the work with the arrangements and those kinds of things. The basically the contractual arrangements between the practices and the CTOs. What they don't want is to have those payments come directly from Medicare and be have to have a participation agreement with Medicare. And payments come from Medicare. They would rather that the practices be paid, and then the practices peel off money and pay the key CTOs individually based on whatever arrangements they have. We had talked about this in the as we started constructing this program to begin with, and thought that that was going to be challenging for particularly small, medium-sized practices to individually arrange for either with a CTO or for individual services. And frankly, it's, this has actually worked, I believe, fairly well. The questions about accountability, other things aside, the ability for practices to make connections to organizations that can provide staffing and other support has been really facilitated by this. And that was one of the issues that our predecessor programs in CPC Classic and CPC Plus said that practices struggle with, particularly small and medium-sized practices' ability to find those resources to allow them to do those things that they need to do in advanced primary care. These also serve, and you can say it's either in a good or bad way, but I believe it's in a good way, to make linkages between community practices and hospitals and hospital systems that was very difficult to arrange before.
The reason why I asked is that the state of Massachusetts Medicaid program has a structure where the state does help with administering a CTO-like service for primary care practices. So that's just what I thought about when I saw that statement, whereby I do agree with everything you said, but if there are thoughts around how that would be or what that would look like, and just lending that insight.
Yeah, that's a good point. And I suppose a good note to Dr. Haft is, is this sentence needed or does it need tweaking? Perhaps that's something you can think about as you're going back through this document final time. I think that's what Dr. Okiki sort of noting is either more clarity or maybe that sentence isn't needed. But we yield to you on how that should look. With that, I would suggest moving on to the track 3. Is it mandatory for participating practices?
Great. Yeah. So this was again a hard line from CMMI that said that to get through clearance, we would need to show how we would be phasing out the current program, track 1 and track 2. And phasing in MDPCP track 3. So we've detailed here in a table of a transition period that would begin in 2023 and end in 2026. So by 2026, there would only be the new starters, and all other practices would have transitioned to track 3 at that time. Track 1 is already scheduled senescence. It was only ever intended to be a temporary place for practices to learn how to do advanced primary care, get this to starting the lower payments until they move to the full payment level, and that would be scheduled to be leaving by 2022. No new starters, and then track 2 would practices would have a period of time to phase into track 3. So I think it was, I think by mutual agreement that we would move in that direction. Also predicated on the fact that track 3 would be a track that would be reasonably attractive to practices and allow us to continue to have broad healthcare transformation across the state.
Okay, thank you, Dr. Haft. Any comments here? Okay, seeing none. Oh, Dr. O'Keefe.
Yes, sir.
So Dr. Haft, just to clarify, at the start of the MDPCP program, it was between 2019 to about 2025. So this is what happens post 2025, and it would be good that if we've gotten to track 3 structure, then we just maintain that going forward.
Yes, essentially.
Okay, so this concludes the policy document review part of the meeting. I don't, unless we've missed something, Dr. Haft, is it fair to say that you have the information you need from the advisory council at this stage to put forth a policy level concept document, and then we look forward to feedback from CMMI and thus then the council getting forward and developing details?
I think that's fair to say. Yes.
Okay. Dr. Reedman, is it any concerns about moving on, or are you? Okay.
No, I agree. I think we got through this. I'm amazed, but I think it's a really good ending point for our starting point. How about that?
Well put. So we have about 15 minutes on the clock. We're estimating the next presentation to take somewhere in the neighborhood of 20 minutes, but I would ask our presenters to be mindful of the clock, and we understand we may run over just a few minutes tonight, but we'll still try to do our best to keep your all's schedules in mind. Dr. Haft, I yield to you.
Very good. Thank you very much. And I think, as I said initially, so I'd like to introduce our actuarial contractors, Optimus, and I think Tim Doyle will be doing a presentation on the work that they've done to take a look at the actual data that we have from our MDPCP practices, and looking specifically at what measures are both actionable and have opportunities for improvement in the primary care side. Tim, turn it over to you, or Chris, either.
Thanks, Howard. First off, can everyone hear me okay? Okay, yes. Great. So hello, everyone. My name is Tim Doyle. I'm a senior actuary with Optimus. For those of you that aren't familiar with Optimus, we are the certifying actuary for the Health Choice program, which, as you know, is the Maryland Medicaid program. So just to give a little bit of a brief overview, the scope of our analysis was to run our tools on the Maryland PCP data and, excuse me, and then determine metrics that could be incorporated based on the results of the tools. And as Howard alluded to earlier, our focus really was on the Part B claims, and at this point, not a focus on the Part A claims. So tonight, what we're going to do is we're going to focus on what we call our Heracles tool. It's an episode-based grouper. So how this is going to work, Chris Welch is going to go through a presentation related to the tool, which will give you a high-level feel for really how the tool works. And then he's going to hand it off to Chris Dickerson, who's going to walk through the results of the tool, as well as the recommended measures. So with that, Chris, you want to start going through the slides?
Sure. Thanks, Tim. So we're aware that there's limited time here, so we've kind of cut this down pretty substantially, and I'll just give you kind of snapshot picture here. But the idea is that we have this episode grouper tool that we've been using in various programs. What it does is it identifies opportunities to reduce costs and improve outcomes. We kind of developed that with a partner focusing on the clinical side, and we do a little bit more of the technical side, the data processing, and some of those downstream analytics. So, how things will shake out if you're able to reduce those costs and improve those outcomes. So we can move on to the next slide here. This is just a little overview of the episode analysis. So there's three basic components there. There's that episode construction, then what we call adverse actionable events in typical care, and finally our roll-up. So the construction, what we do is we're looking for diagnosis codes, procedure codes, or combinations that would trigger what we're calling an episode. So something that might be an episode is, for a chronic condition, would be diabetes, for example. And then looking at all the clinically relevant services related to, in this case, diabetes, related to that episode. Once that episode is defined, we look at the services that were offered within that episode, and how they relate to the episode, and whether they would be something that's what we'd expect as typical care, or something that could potentially be avoided, which we've called adverse actionable events. So you'll see that that term used, AAE. That's essentially things that could be avoided, and we'll have an example coming up in just a minute. But you'll see that used in the analysis that Chris Dickerson's going to show you in just a second. We also do an episode roll-up. So there are some episodes for a grouper that are those chronic conditions like diabetes, and other ones might be more procedurally focused. We also recognize that, some folks have, for example, diabetes and hypertension, and so there can be some overlap there. And so, ultimately how we roll this out, we account for that overlap and don't do any double counting. But for the purpose of what we're showing you today, we're trying to keep everything within its own episode group. So we'll get into that in a second. Then the next thing here is just to give you a brief idea about the episode construction. Like I said, we have that trigger event. We're looking for a combination of a procedure code and a diagnosis code. We'll look back in time and forward in time around that trigger event. And that amount of time that we look back or forward is really dependent upon the specific episode. So for example, a procedural thing, if you go in for a surgery, there might be a smaller look back window and forward window. But if you have something like diabetes, that's going to be kind of a chronic condition, then that would be something that lasts a lot longer. And we have just kind of a little picture down there at the bottom. Again, when we're looking at these episodes, we're really trying to focus on what's clinically relevant. So if there are, if each of those hexagons at the bottom there is a service that's performed during that episode, we're really only focused on the ones that are related from a clinical perspective to that episode. So they have, diagnosis codes and procedure codes that would map to, for example, diabetes. And then I think we've got one more slide here, which is just an example we have for diabetes. If someone, for example, went into the emergency room as a result of their diabetes, that might be something that's an adverse actionable event. In June, we would expect that they'd see their primary care doctor, in support of that condition. So we've, for example, here listed that visit as typical costs, and that's not something we'd expect to be removed or that would be eliminated. But then if, it was poorly managed and there's an inpatient admission for hyperglycemia, then that's something that would potentially be removed or, that we think might be avoidable. And then again, another primary care visit with the HbA1c test. That's something we'd expect to be typical. So we have that trigger event in the beginning. There might be a look back period before and a look forward period where we're trying to identify which costs would be typical, which ones are adverse actionable events, that AAE. And for the scope of what Tim was describing and what Chris will get into, we've really focused this on those PCP settings, the MDPCP program. We have talked a little bit about how this might have those downstream impacts, in hospital settings or with specialists, but that's not in the information that we have available at the moment to share with you all. So I know kind of flew through that really quickly. I'm sure some of you are familiar with similar grouping tools, but are there any questions just kind of in general before we start looking at some of the results?
Okay, I think you're good to keep going. Oh, Dr. Berenson.
Yeah, this needs a longer discussion, but I think one of the real challenges in groupers is people with multiple chronic conditions. Patient has diabetes, renal failure, congestive heart failure. That's not an unusual constellation. They're admitted for dehydration. How do you apportion that? Do you actually apportion it, or do you just say that's an acute illness that's not necessarily related to any of those three, or what do you do?
Yeah, that's a great question, and we'll get into this a little bit more as we walk through the summary of results. But essentially, we look at each episode as kind of a complete universe. So that will double count some dollars for people with multiple chronic conditions. So if someone has care, if they have multiple chronic conditions and they have care that could pertain to all three of those, that service would be counted for all three of those. We'll cover that overlap of dollars a little bit more in the summary tab.
Because I've seen another grouper that sort of allocates a proportionate amount to each, but you're actually double or triple counting.
Yeah, it depends on how we're going to look at things. If we're trying to look at the total dollars in a program, then we don't want to be double or triple counting things. Then we will have some sort of appropriation logic.
You can adjust it for the purpose. You can actually change the allocation rules based on what you're using it for.
Exactly, that's correct.
Okay, that's good. That's interesting. Okay, that's all. That was a quick question.
All right. So now, my name is Chris Dickerson. I'm an actuary with Optimus, and I'd like to walk you through the results that we've seen from our first run of the Medicare PCP data through the Heracles grouper. Before I do that, I want to just cover some basics so we can all know what we're looking at and what we're talking about. First, the time period for our data is 3 years of data, October 2017 through September of 2020. The 3-year time period is very important due to the nature of the grouper and the look back and the look forward periods that Chris Welch mentioned. We can look at smaller time periods, but it starts to get to be a not ideal interpretation of the grouper. If we want to look at results over time and changes from maybe 1 year to another year, what we would recommend is rolling 3-year periods. So maybe you would do an October 17 to September 2020 study, and then do an October 18 to September 2021 study, and then use the comparison of those two studies to determine how performance has changed over time. Everything we talk about here is going to be limited to beneficiaries enrolled in Medicare Maryland PCP program. So that's our entire universe for analysis here. We further will have some analyses that are limited to just providers participating in the PCP program, and I'll delineate that on the next tab when we talk about that. The dollar fields that we're using in this analysis for now are more along a charge basis. So if you're familiar with the Medicare data sets, on the Part A data, it's revenue charge, and on the Part B data, it's the claim line allowed charge amount. This is something I mentioned a little bit already, but for overlapping episodes, dollars will be counted towards both episodes in the summary table we go over. And then also the summary table that I'll show, we've just picked the most consequential episodes, and of those episodes represent about 84% of the total PCP spend. So we are capturing the majority of the episode-based PCP spend with these episodes that we'll focus on. Now on the summary tab, I want to talk about this top table first. Let me zoom in a bit for it. Mutually exclusive dollar breakdown. So here we are not double or triple counting dollars. Everything is mutually exclusive. Across the entire 3-year period, all services combined, we have about $14 billion in charges provided to members enrolled in the Maryland PCP program. Of that, about $4.5 billion comes from the Part B data, which the way the data files are laid out is really the professional Part B data, no outpatient hospital Part B data. Within that, we have about $452 million that are provided by the PCPs enrolled in Maryland's program. So that $4 billion is a lot of specialty providers, a lot of surgeries, things like that, that were not provided directly by a PCP participating in the program. Finally, after we run the data through Heracles, Heracles identifies $332 million associated with an episode. Now this, to the slide Chris pointed out earlier, is a combination of typical care and a total episode dollars. Now I'm going to zoom out a little bit so we can see this full table. Now what we've done is we've sorted the data by episode with descending dollars, and we've identified the AAE dollars and the episode dollars and the corresponding AAE rate. So for diabetes, we found $23 million in potentially actionable avoidable events, or adverse events, and $85 million in total episode dollars. That shows an AAE rate of about 27%. So the Heracles tool has identified that 27% of the total diabetes spend provided by the participating PCPs is something that could be considered actionable and adverse. The next column is the key drivers of that AAE spend. So these are going to be kind of a higher level grouping of the diagnosis codes that indicated something was an adverse event. You have diabetes, poor control, urinary tract infection, and you can see down the list down to hypotension or other bacterial pneumonia. The next section, we have identified applicable quality measures from NQF, HEDIS, and ECQM that could pertain to these key drivers of adverse actionable events. And over here is just kind of a description of what those measures are. little verbal, sentence or so description of it. Measures that are shaded this tan or orange color, those are outcome-based measures. That way we can kind of quickly delineate outcome-based measures from non-outcome-based measures. Now, as we go down here, you'll see that there are multiple different episodes. So diabetes, hypertension, COPD, heart failure, low back pain. These dollars get to the point that I was talking about earlier of no longer being mutually exclusive. So if you look at this section, you are looking at the universe of diabetes, which, to the point that was raised earlier, could include some expense for individuals who also have hypertension. There is going to be some overlap here. Because of that, the sum of the dollars in column C and D here, they will not match up to the table up here. This 332 million will be less than this, because you can see that like right after a couple episodes, we're at nearly 300 million already because of the comorbidities associated with the Medicare population. So as we look through this, you can see that there's going to be some conditions that maybe have less in terms of dollars associated with actionable adverse events, but a fairly high rate of AAE. So COPD and heart failure are examples of that, where we're talking about $5 to $10 million, but it's about a fourth to a fifth of the total dollars spent on these services. While something like hypertension has a much better rate, only about 10% of the dollars are associated with AAEs. However, it's nearly 23 million. So I think given the time limitations here, we probably won't go through these measures in great detail. These are measures that we've walked through with our staff clinician to get his thoughts on what can be used within each of these three quality metrics to help control urinary tract infections, help avoid acute chronic congestive heart failure. So these are all things maybe we can look at and discuss at a later time. The last comment I want to make is back up here. You can see that what we're really focusing on is a universe of $330 million. And again, this is services provided by a PCP participating in the program to a member who is attributed to that PCP. If we expand to the total universe, there's $14 billion here in services provided to those members. So that's a big gap, and that's something that we're really excited about for a potential phase 2 of this project, is looking a little bit more into that and looking at hospitalizations associated with these conditions and how we can link that to the attributed PCP and try and coordinate the whole healthcare system to avoid unnecessary care and adverse events. So with that, I see we're kind of at time, so I'll pause and open it up to any questions.
Okay, thank you. So with that, are there any general questions for our friends here today from Optimus? It is a lot to take in, and I suspect, Dr. Haft, that we'll be coming back to this.
Tim, are the totals, do they include drugs?
The total dollars up here will include a small amount of Part D data, but it will not include any down here. This will be only services provided directly by PCPs. So it would not include any referred prescriptions or anything like that.
And although you have the PCP episode dollars, you have the total episode dollars, which would be derived from the total dollars.
Yes, we do not have, we have that in our data, but we do not have that readily available in this summary.
Okay, good. All right.
I think I saw a hand from someone, and I may have missed that person. Dr. Okiki.
Yeah, just doing the math, and I'm going to test my actuarial skills here. The PCP dollar seems to be right around 3% of total, right?
Yeah, I believe that's correct. Let me do total PCP dollars.
It's 3
I always try to think about that when we start thinking about potential savings, and wondering if, again, the PCP spend is where it needs to be for the kind of results we're looking for. Just an observation.
And just again, to make sure we're explaining our fields clearly, this is a PCPs participating in the program. So there will be PCP spend for PCPs who are not participating in the program. That will be part of this 4.4 billion, but not part of this 452 million.
Okay. I think Stacia has a question or comment.
I just want to make sure I'm not misinterpreting this. So am I hearing you say that you would identify, for example, in diabetes, that the actionable opportunity was 23 million? So is there a roll-up number of what you saw as actionable opportunity in the data here?
Across all of the episodes?
Correct. Knowing that there is some duplication, I'm just trying to understand, what the potential size of the impact is, and that presumes that we were able to effectively eliminate all avoidable utilization, right? The AAE is what we see as potentially avoidable. Is that a fair way to interpret this? I don't want to misinterpret the data.
Yes, no, I appreciate the question. And the sum of the episodes on the table right now is about $100 million. But I do want to clarify that this is just services provided by the PCP.
Correct.
And I think from a care reform perspective, where the PCPs can have the most impact is for avoiding hospitalizations and avoiding some of those bigger ticket items that are not currently part of this. For phase one, we're going to start with things that are directly under a PCP's control. So I acknowledge it's a smaller figure compared to the 14 billion total dollars, but it is something that is provided directly by a PCP and theoretically be very much under the PCP's control.
Okay, so your estimation, and recognizing there's some duplicative expenses represented here, but that there is about a $100 million opportunity. Is that a fair characterization?
I'd rather follow up with the precise number because in addition to there being some duplication, there are some episodes outside of this. On the notes slide, we mentioned how we're talking about 84% of the total episode dollars with these key conditions. So if it's all right with you, I'd rather follow up with the exact number just to make sure we're being precise with that.
Okay, that's helpful. Thank you.
Any other comments? Dr. Haft.
Nope. I'd like to thank everybody again. This was, again, a great discussion, very healthy, balanced, and appreciate all of the comments and input. I think we're moving forward and making some good progress, and hope that you all have a restful and joyous holiday season. And I'm sure we will meet again early in the new year, hopefully with many more people vaccinated and seeing more clearly the light at the end of the COVID tunnel.
Yeah, agreed. So, Dr. Riedman, any remarks, and then Melanie can do the opposite.
I'll make it very brief. I started off these meetings months and months and months, seems like years ago, but months ago with 3 criteria. I think I've mentioned them numerous times, but I think the last one was what I agreed to do. This committee was it would have an impact, and I really do hope. I think we put a lot of effort into this. I think we've come up with some really key points that we presented tonight, and I really do hope that we have the impact that we hope we will. It certainly will make all these meetings worthwhile. I'll also end with everybody have a great and healthy new year. Look forward to some less frequent but important meetings next year.
Thank you, Dr. Riedman. Ben, any comments for the group?
Well, echoing what everyone else said, and I would note that I think Dr. Haft had his Santa Claus appear tonight, and so he should be particularly happy. I want to thank all the council members. I know that absolutely not perfect alignment, but I think there's great directional agreement on where we want to go, and it gives us a good footing to square up with our colleagues at CMF to try to push these ideas forward. So thank you very much.
Thank you, Ben. Melanie, the ops piece, please.
Yeah, so as was mentioned, we won't be having any more meetings in 2020. We will be reconvening sometime in 2021, and we'll let you guys know when that will be. There will be high-level summaries available from the meetings and reportings from all the meetings on our website. If anyone has any questions about any materials, our team would be happy to point you to them.
Okay, and closing out, I echo what everyone else said, so I won't hold you all up. It's been a pleasure to collaborate with everyone here, and I look forward to talking to you in 2021. Oh, Dr. Reedman.
Thank you for your leadership, everyone.
I have to say the same thing. I have to say that one of the pleasures that has been working with the committee and particularly the Maryland Healthcare Commission members and Dr. Haft, it's really been a pleasure this year. So it's been a tough one, but I really appreciate all y'all have done for us. So thank you very much. Have a great holiday.
Cheers to 2021.
Bye-bye. Thank you very much, Maryland Healthcare Commission. You're great.